Hello, everyone. Welcome to our webinar. And our topic tonight is preventing stomach and colon cancers. I think you'll remember tonight because you're going to learn so much interesting information. Let's go to our welcome slide. For all of us church folks, when we grew up, it was a welcome. We welcome you once, we welcome you twice, we welcome you 3 times. Well, now we can just say welcome, and we hope you feel welcome as we go throughout the night. Next slide, please. My name is Pegy Tatum. Most of you probably know who I am. If not, I tell some folks I'm the best kept secret in Raleigh. I want to tell you about an experience. I have a company called The Connection Place, and under The Connection Place, we have different entities. And one of the entities is the Female Pastors Fellowship. We also have a gospel choir, we have a magazine, we have Women of Triumph. But tonight, this one particular group that we have, the Female Pastors Fellowship, came to the attention of some great doctors. One of the people on our team, Amanda Mandy, she was ranting one day on Facebook about the GI issues and people not taking care of themselves. So I invited her to come to one of our meetings. Well, she came. It was a Zoom meeting. She said, "Can I bring some doctors with me?" And I said, "Yeah." So she brought some doctors that you'll see tonight. And we talked about gastrointestinal issues, cancer, how to take care of yourself. And they thought that we would be good community partners for the Duke Cancer Center. So the picture you're seeing, I'm just saying, this is how Amanda and I were so happy once we found out that we became community partners and we got a grant so that we could educate our community about GI issues, getting tested, eating healthy, just so many things we want to educate you on. And so tonight is the night that we start our quest. You'll be talking about or hearing about the gut patrol for a long time. We're here for the long haul. So let's get started and see what the gut patrol is all about. Even when we started this venture, we didn't start by ourselves. We had folks from the Duke Cancer Institute that stepped in as our advisory team, and they sort of guided us along the way. And I am so glad you'll see them tonight. And let me toss you over to Jessica Goodwin. Jessica is one of the interns, and let me tell you a little bit about her, other than she's just as cute as she can be. Clinical research intern for DIRECT, a cancer fellowship program, diversifying research and experiential learning in cancer training at Duke Cancer Institute. She's a trainee. She's one of our interns. And thank you, Jessica. You can take it from here, and I'll see you all later, okay?
Thank you, Ms. Pegy. So I'll be introducing our first speaker, Dr. Julius Wilder. Dr. Wilder is an associate professor at Duke University. He works particularly with the Duke Department of Medicine, Diversity, Equity, Inclusion, and Anti-Racism Committee. And he's also a co-director for the Duke Community Engagement Research Initiative. He's a member of the executive board for the African American COVID Task Force and the AME Zion Health Equity Advocates and Liaisons. Today, he'll be talking to you about colorectal cancer. Thank you, Dr. Wilder.
Certainly, thank you all so much for having me participate in this. It's an honor to be here. And I'm really excited about this event, and thanks so much to everyone for putting this together. So what I'd like to begin with is to really just take a couple minutes and give an overview about colon cancer, sort of what we mean when we say colon cancer, to give you a sense of, what are some of the risk factors for it, and speak to some of the options for screening. Because colon cancer is one of those things where if we are screening, we can actually make a difference in terms of the risk of actually having colon cancer. Next slide, please. And so, the thing that we talk about in GI, I'm a gastroenterologist. I do procedures, I do upper endoscopies, and I do colonoscopies. When we do colonoscopies, looking for the thing that you see here on the slide, that the particular slide on the right is a polyp. And you can see the little snare there going around that polyp, and that snare is going to get really tight, and we're going to send a charge through that little loop that you see there and cut that polyp off. And once that polyp is gone, it is no longer a problem for you. And this is why screening is so important, because we remove that issue, and theoretically that should not be a risk for you moving forward. And on the left, you can just get a sense of the sort of some of the anatomy around the kinds of polyps we see. Sometimes they look like little donuts that sit on the surface of the inside of the colon. Sometimes they look like the polyp on the right, where they look like a little mushroom that's growing out. But what we want to do is to try and get these polyps out while they are normal, benign polyps, just sort of very docile and not a problem. Next slide. Our concern, as you can see here, is that what can happen to these polyps over time if we don't get them out. Unfortunately, what you see here is a colonoscopy where a mass is seen that is malignant. And this is not something that we can just take out easily like we saw on the last slide. This person has colon cancer. This person is going to require probably surgery. And depending upon other sort of factors involved in terms of whether there's any evidence of cancer anywhere else, so forth and so on, they may require things like chemotherapy and so forth. But for the most part, we want to get the polyps out before they get to this point. Okay. Next slide, please. And so let's talk about, could we talk about screening for colon cancer? Well, how big a deal is this? And it really is a pretty big deal. I mean, it is a disease that is fairly common. And so our estimates right now for 2022 from the American Cancer Society notes that they expect around 151,000 new cases of colorectal cancer just this coming year, and around 53,000 deaths in the setting of that. So that represents of total cancers about 10% of the total amount of cancers we'll see this year. And so if you look at a person, like a group of people, over their lifetime, how many of them will get colon cancer? About 1 in 23 people, will develop colorectal cancer over the lifetime. So we all know 23 people pretty well, right? And so you can imagine that one of those people in that group of people you may know with about a 4.3% risk of colon cancer over their lifetime will develop it. And so it's a disease that we see fairly common. And obviously the importance of screening is key, right? So that we can prevent this from happening. Next slide. So while we talk about those numbers around colon cancer sort of screening and colon cancer incidence, how often we see colon cancer happen, we do note that as I mentioned, the actual amount of colon cancer that we see has gone down. That's largely because of screening. And there's sort of two factors involved in that. Remember in that first picture I showed you that polyp? Well, so it takes time for a normal looking polyp or a normal regular polyp to become cancer. And so that lag is why the screening is important, because we can actually go in there, take a polyp out, as I mentioned earlier, before it becomes colon cancer. And so when we think about what we have seen in terms of this trend, right, this improvement in the amount of colon cancer we see, generally speaking, we know that actual screening has contributed to those better rates that we've seen. Next slide. And so, there are a couple of things to think about when we think about colon cancer and where we see it and who gets it. As you get older, your risk of colon cancer increases. And that's actually partly why we wait until you're a certain age before we actually recommend you begin screening, because we know after this age, you're at higher risk of having colon cancer. And so that the risk of colon cancer doubles for every decade of life after age 40. And so, if this person's 55 and this person's 45, going from 45 to 55, your risk doubles just in those 10 years. When we look at where, the people that we diagnose colon cancer in, the vast majority of those people, 90%, are over age 50, okay? We see more colon cancer in men. We see it more in African Americans and in Native Americans. And if you have a family member who has colon cancer, and we'll talk a little more about this later on tonight, if you have a family member with colon cancer, then your risk of having colon cancer is also much, much higher. Next slide, please. And then, as I mentioned, so age, if you have a history of polyps yourself, meaning if you've had polyps in the past, having your follow-up colonoscopy is really important, because you make polyps, and making polyps is important, right, to driving the risk of cancer. As I mentioned, family history, there are people who have genetic issues or things like inflammatory bowel disease. So your genes can create an environment where you're more likely to have colon cancer develop. And then things like diabetes, obesity, frankly, we mentioned earlier, race and ethnicity can be associated with higher risk factors as well. Next slide. Now, there are also a couple of things that we can control, right, that can impact the likelihood of you having colon cancer. You know, whenever you think about health issues, there are often things that are, you know, things that we can do something about, right? And there's some things that we can't control. You know, diets that are high in red meat and processed meats, bologna, bacon, you know, those diets, especially if they are not well balanced with vegetables and fruit, are going to create an environment in your colon where you're more likely to have colon cancer. Again, physical inactivity, as I mentioned earlier, obesity, smoking and alcohol, these are things that we know increase the risk of polyps and as well increase the risk of you developing colon cancer as well. So there are a couple of things when you think about your daily habits that might be helpful in terms of, you know, overall decreasing your cancer risk as well. Next slide. So screening, I've said it like 1,000 times at this point. You know, it's so important because we know it can make a difference. And so for most folks, and in fact, this is new because it used to be the screening age is 50, but now we're saying age 45 for the average patient. Now, as I mentioned earlier, there are some people who have a family history of colon cancer, particularly if it's a first degree relative, right? So your mom, your dad, brother or sister, you know, then your risk of colon cancer is much higher. So we actually suggest you start screening a little bit earlier. And typically we say you start screening 10 years younger than the age of the person, youngest affected person with cancer, or age 40, whatever it's going to be sooner. And you can talk to your primary care doctor about the timing of it. But the important thing really is really to recognize the family history of colon cancer and knowing that you need to start your screening earlier. Now, when you screen, there are many different ways to do a screen for colon cancer. But once the screening starts, the timing of when you do your next screen or surveillance, as we may call it, will depend really on how you screen and you know, and what the results are of your screen. And you can talk through all this with your primary care doctor. It's a conversation I definitely think you need to have if you have not had yet, especially if you're age 45 or older. And I also recommend to all my patients that if you have a family history of colon cancer, you know, and we'll talk more about the types of tests you can do, but I do recommend an actual colonoscopy in that setting because of the high risk of colon cancer that occurs in people who have a family history. Next slide. And so, as I was just mentioning, there are different ways to screen. And so, you know, there are what we may call invasive ways and non-invasive ways, right? And so a non-invasive way may be a way that doesn't really require you to go to the hospital, doesn't require you to, you know, do a formal examination or do a prep like you might for a colonoscopy. These often involve you providing a sample that you then submit to the lab. And that sample often will have some stool in it, you know, stool sample, and they'll look at the stool for things like blood and other evidence in there of polyps or really cancer. Okay, and because those are really good at detecting cancer. And the thing to keep in mind is that with those types of tests, right, the tests that you just kind of do at home and you submit to a lab, if they're positive, you will then have to go get a colonoscopy. So the other type of examinations or the structural examinations, the ones that can look at, you know, for evidence of cancer as well as help understand if there are any polyps in there, are things like colonoscopy. There's a special CT scan, right, an imaging scan that can be done to look for polyps. And that's often done in people who are not healthy enough to have a colonoscopy but need it. And then there's a sort of thing, something called a flexible sigmoidoscopy. That's actually kind of a half colonoscopy. You don't go all the way throughout the entire colon. You only go about halfway and look at the bottom half of the colon. We often see a lot of colorectal cancer in that bottom half of the colon, especially in the rectal area as well. So there are a couple of different sort of modalities that we can consider when thinking about doing this screening. You know, the colonoscopy allows you to look directly at the colon. You do have to do a prep in preparation for the colonoscopy so that we can see when we're doing the procedure. And nothing's perfect, right? And so there's a small chance of missing large lesions. And, you know, there's risk of bleeding and perforation. And there often is sort of sedation required for that as well. Next slide. So with colonoscopy, that's going to be every 10 years, but that can vary a little bit depending upon, you know, what your underlying, you know, findings are. Oh, sorry, was there a question?
No, sorry, time's up. It's only 10 minutes, unfortunately.
Oh, okay. I'm sorry. Well, if there are any questions I can answer about screening or anything like that, just let me know. But they definitely know these polyps do have a significant impact and drastically decrease your risk of colon cancer. So thank you. And any question I can answer, just let me know.
Thank you so much. Our next speaker is Dr. Mira Epstein. She is a cancer epidemiologist here at Duke. Her focus is to work on lowering the association with H. pylori and gastric cancer. So she's going to talk to us today about stomach cancer.
Thank you so much, Jessica and Peggy and Amanda and everyone for putting this together. So happy to be here to talk to you about preventing stomach cancer. So next slide, please. So stomach cancer is not as common as colorectal cancer, as we just heard from Dr. Wilder. It still is the 5th most common cancer in the world, and unfortunately it has a high fatality rate. So it's the 3rd most common cause of death from cancer in the world. And in the United States, it is a cancer usually of older people. So the average age of diagnosis of stomach cancer is 68. And again, kind of a rare cancer, and yet 27,000 people each year in the US will be diagnosed with stomach cancer, and about 11,000 people each year in the US will die. So this equates to a risk for a US man of about 1 in 95. So it's more common in men than women, and a risk for a US woman of 1 in 154. And unfortunately, the 5-year survival rate, so those folks who live 5 years after diagnosis, is only 30%, which is really disappointing, but it is 69% if it's caught early. So that's one of our goals, is to catch stomach cancer early. Next slide, please. So the other big issue with stomach cancer, it's a really disparate cancer, in that it occurs at different rates among different people. And specifically in the US, people of color, African American, Asian American, Latino, American Indian, Alaska Native, Pacific Islander, are 2 to 3 times more likely to develop stomach cancer than whites. And again, as I mentioned, because it's a highly fatal cancer, it's actually the 6th leading cause of death from cancer among African American men, after lung, prostate, colon, liver, and pancreas. So it doesn't reach the top 10 cancers for any other group of men or women, but really important, especially in our African American male population. Next slide, please. So just to reorient you, the stomach is up there highlighted. The esophagus comes into the stomach, and then the stomach empties into the small intestine. Next slide. And the reason I just want to mention a little bit about the actual stomach itself, it's this hollow organ, right, where it digests food, is that it's important to know there that stomach cancer is often described as cardia versus non-cardia stomach cancer. And the reason is just they may have different causes and slightly different outcomes. So cardia is that top part of the stomach you see there right by the esophagus. Non-cardia is pretty much the main part of the stomach, the rest of the stomach, that's not that top part. And non-cardia is the majority of stomach cancers in the United States. So what are the symptoms for stomach cancer? You know, not surprisingly, they're really similar as the symptoms caused by infection with the bacteria Helicobacter pylori, which causes the majority of stomach cancers in the US. So these symptoms include a poor appetite, unintended weight loss, belly pain, discomfort in the upper abdomen, fullness in the upper abdomen after eating a small meal, heartburn or indigestion, nausea, vomiting, swelling or fluid buildup in the abdomen, blood in the stool, and low red blood cell count or anemia. Risk factors for stomach cancer. So in general, there is increased risk, just as Dr. Wilder mentioned, for colorectal, for stomach cancer if you have a family history, especially again in those first-degree relatives, so your parents or your siblings. There are also some known inherited cancer syndromes that are associated with a number of different cancers that include stomach cancer. So that's Lynch syndrome, also known as hereditary non-polyposis colorectal cancer, FAP, Lee-Fraumeni syndrome, and the known breast cancer mutations BRCA1 and 2. Specifically for cardia stomach cancer, that part of the stomach up near the esophagus, we see associations also with being overweight or obese. For non-cardia stomach cancer, it's a slightly different group. We know smoking increases your risk. Diets low in fruits and vegetables increase risk, and then diets high in smoked foods, salted fish and meat, and pickled vegetables. And again, the number one risk factor, though, is infection with this bacteria, Helicobacter pylori, which, as I mentioned, causes the majority of the non-cardia stomach cancers. So what is Helicobacter pylori? It's a really fascinating bacteria, actually. It infects half the world's population. In the US, we think 30% of the people in the US carry this bacteria that infects the lining of your stomach. We believe that the mode of transmission is oral, vomitous oral, or fecal oral. We really have only established humans as the known reservoirs. People look for H. pylori in the water and on other surfaces. That's not as well established. What's really important about Helicobacter pylori is that there is effective antibiotic therapy. So the antibiotic therapy I'll describe a little bit more in detail later, but it's 2 weeks of antibiotics and a proton pump inhibitor, and it can be very effective, but there are issues about increasing antibiotic resistance among some of the bacteria. It is considered a class 1 human carcinogen because of its association with an increase in risk of gastric cancer. H. pylori also causes gastritis, peptic ulcer disease, and a kind of cancer called malt lymphoma. So interestingly, we don't talk a lot about H. pylori in the US, but it's responsible for more new cancers than any other infection. So more new cancers than human papillomavirus, which is so exciting that we have a vaccine for HPV to reduce cervical cancer and hopefully head and neck cancers too. And hepatitis B virus, we have a vaccine, and hepatitis C we treat, which are risk factors for liver disease and liver cancer. And yet I feel like it's the cancer-causing infection that people know the least about. In fact, these two friendly Australian doctors won the Nobel Prize in 2005 for their discovery of Helicobacter pylori. Their discovery was that a bacteria could live in this highly acidic environment of the stomach. And they just saw the association specifically with gastritis and peptic ulcer disease. Prior to this, people thought you got ulcers from stress. And I won't say that stress might not be a cofactor, but actually at the time, most ulcers were caused by infection with Helicobacter pylori. And we later learned of its association with stomach cancer. So I just want to give you a quick little demonstration of the natural history, just to say that, as I said, lots of people have H. pylori. So 30% of the US is going around carrying H. pylori. And if you hit the next slide, you'll see that the majority of people, that big arrow in the middle of this slide, the majority of people, 85% of people who have chronic H. pylori infection, again, you're usually infected as a child by your mom or your older siblings, actually have asymptomatic, so no symptoms, and the H. pylori doesn't do enough to really cause problems. It's really the minority of folks whose H. pylori causes an ulcer, or again, maybe about 3% or less people with chronic H. pylori will ultimately develop gastric cancer. So just because you're diagnosed with H. pylori right doesn't mean that you have stomach cancer or you're going to get it. But if you get tested and treated for H. pylori, you're going to significantly reduce your risk. And testing for H. pylori can be non-invasive, a breath test or a stool test. You can also go into the gastroenterology suite and have an endoscopy to not only test for your H. pylori, but to see if there's any outcomes from the H. pylori itself. And as I mentioned, the treatment is, just 2 weeks of 2 antibiotics and a proton pump inhibitor, sometimes bismuth too, which could be hard on people's stomachs. If you have a hard time with antibiotics, you might have to be prepared for some side effects similar to upset stomach and diarrhea. But again, 2 weeks and to significantly reduce your risk of stomach cancer. I'm about out of time. So next slide. I just want to mention, if you do get tested and treated for H. pylori, you need to get retested 6 weeks later and just make sure that the treatment worked. And if it didn't work, we'll give you another regimen of treatment to make sure we eradicate this bacteria. Again, you can cut your risk in half by eradicating your H. pylori. And I think our last slide, we'll skip over these slides if that's okay, and just head to the next one. Here, this is the last slide. So what else you can do? I'm a big proponent of getting tested and treated for H. pylori if you're at higher risk or you have symptoms. A few other things you can do. Don't smoke. If you do smoke, try and quit. We have a great smoking quit line here at Duke that can help you out. Try to decrease your intake of salt and salted foods, especially processed red meats like ham and sausage and bacon. So if you eat it regularly, try to eat it less. Try to increase your intake of fruit and try to get to and stay at a healthy weight. So that's it. Thank you so much for listening. And I'm excited to take questions at the end.
Dr. Epplin. Our next speaker is Dr. Catherine Garman. She's a gastroenterologist here at Duke, and she's here to talk to you about how you can go speak to your doctor about all of these issues.
Hi, everyone. Thank you so much for the invitation. It's really a pleasure to be here, and thank you for organizing this important topic. So I think I have kind of a fun session, realizing that it can actually be really hard to talk to your doctor. And so I hope that there are going to be some helpful tips here. We can go on to the next slide. So I think it's good to just step back and look at where we are in the world right now. So what's changed in the pandemic? I think for some of us, it feels like everything. And it may not even feel like it's a priority to go to the doctor to talk about issues that you might be having with your GI health. And certainly for many of us, cancer screening is not high on our list right now. We're busy trying to take care of family responsibilities, which have changed for many people. Working remotely is different. And the way that we connect with our doctors is also different. And connecting over telehealth may be different. Of course, as Dr. Wilder showed you, it's difficult to do a colonoscopy virtually, but there are many appointments that are happening virtually, and that might be a great thing for you, or it might not feel as comfortable. I think it's also really important to recognize that chronic stress is taking a toll on many of us right now. And in the GI clinics, we're definitely seeing problems with stomach pain, nausea, as well as headaches, trouble sleeping, and lots of other things related to stress right now. And it is totally reasonable to talk to your doctor about those things. And also, as we start to get back to a different mode of being in the world, to start to think about things like cancer screening again and dealing with symptoms that many people have been putting off during the pandemic. Next slide, please. So this is a picture of what I look like when I am in the endoscopy suite. And I put this here for a couple of reasons. One, I think it's kind of a funny picture, right? So we wear a lot more protective garb. Even in the clinic, your doctor might be wearing scrubs. My husband likes to joke about my scoping bonnets that I wear for hair protection during COVID. And honestly, some of my colleagues don't even recognize me when I'm in the clinic because I'm so covered up. And that may feel uncomfortable too, talking to your doctor when everyone's wearing masks in the clinic. I know when I went to see my own doctor for the first time, she was wearing a face shield, and it just felt like there were more barriers. So it may be good to just be prepared about that. The other thing is that sometimes doctors avoid going to the doctor too. So many of us don't really feel comfortable on the patient side and being on the receiving end. And so it's good for all of us to remember that it takes time to build trust, sometimes to rebuild trust if you haven't seen your doctor in a while. But it is important to take good care of you. And I will freely admit that when I was filling out the questionnaire, registering for this, I thought, oh, I am overdue for some of the things like colon cancer screening that it's now time for me to do as well. So we are all in this together. Next slide, please. So I think one thing that can be helpful to remember, especially if you're going to see a gastroenterologist, is there is actually very little that will embarrass your doctor, and it may feel really strange to you. You may have even noticed doctors speak almost a whole different language. When we go to medical school, I felt like I don't come from a family of doctors. I had to learn a whole new set of words and just ways of thinking about things, and that can feel like a barrier too. But use your words and ask your doctor if you don't understand the words that she's using. My kids think it's hilarious that I'm a gastroenterologist, and they are very comfortable talking to me about pretty much anything. There is nothing that will embarrass your gastroenterologist because we've heard everything. So please do know that even if it feels really uncomfortable to you, we can handle it, and we are not going to laugh or make any snarky comments. We are here to support you, and we've pretty much heard it all. The other thing that's really important to remember is you know your body best. You know the barriers that you are facing in your life about going to see the doctor. You know how you feel. If we give you medicines to treat H. pylori, like Mira was talking about, and you feel really lousy taking them, we need to know that, even if it's uncomfortable. We want to partner with you, and that takes clear, honest communication, even if it's hard. I'm chuckling looking at the comments in the chat. Yes, there's nothing that will embarrass us. I tell a lot of my patients, I have children of an age where gas is like the funniest thing ever. So no, we totally understand. Next slide, please. All right. So there are some things you can do to prepare to help your visit with your doctor go well. It's helpful to list out questions and concerns and bring them with you. I have to remember to do this too. I get flustered. I don't like going to the doctor. And so keeping a list on my phone or on a piece of paper can help keep me centered about what's most important to me, because your doctor really does want you to help prioritize what's most important to you. Now, the other side of that is that there are some things that you might report that maybe you didn't think much of that we see as a red flag, something that says, oh, that might signal a really important problem, and we're going to ask you to follow up on those. So those are kind of that give and take of you tell us what's important, and then we're going to also talk to you about things that we think are important, and we come together to take good care of you. And we're going to talk a lot more about red flags. Next slide, please. There are some worksheets that the NIH has prepared that you can find on the NIH website, and these slides include some of those links. And this is just kind of a picture. This isn't a complicated list here, but you might want to list out in advance the name of the doctor you're seeing, remind yourself where that clinic is, or if it's online, how to do that telehealth appointment. And then you can start to list out the things that are most important to you to talk about to make sure that your concerns get addressed. Next slide, please. So red flags. Red flags are symptoms that your doctor is going to take really seriously because they might signal a bigger underlying problem and might trigger further evaluation like a colonoscopy. Next slide, please. So some of the red flags that we really do want you to tell us about if you're experiencing them, even if it's uncomfortable. As gastroenterologists, we want to know if you're having bleeding. So vomiting blood, having bowel movements, or poop that's really dark and sticky, that doesn't smell very good, has a special medical name that's melena, that can be a signal of bleeding from higher up in the GI tract, maybe from the stomach, that blood getting partially digested. And I'm sorry that this is gross, but it is what it is. And then it comes out as this really dark, kind of stinky, sticky stool. And you kind of know it if you have seen it. But we want to know about that because that's something that says, oh, we should take a look and make sure there's not an ulcer or something that's causing a problem with bleeding. If you see red blood in a bowel movement, we want to know about that as well. Sometimes it's something like hemorrhoids, it's very common, but sometimes it's a signal of something more concerning, and we definitely want to know. Weight loss is something that we also think about. If you are clearly working hard on a diet and exercising and it's very intentional, that may not be quite as concerning as a scenario where you start losing weight and you're not really sure why. I think for GI things, this also includes just having so much difficulty eating that you're losing weight. So any weight loss, we definitely want to know about. And this is one of those things in the pandemic, if you haven't been to the doctor in a while or been doing telehealth and haven't been weighed, you may not even realize all of this. Diarrhea that wakes you up from sleep is something that we worry about for some of the inflammatory conditions. Even though this might be really hard to talk about, we definitely want to know about this. Difficulty swallowing is also something we take really seriously. If you have pain when you swallow or the sensation of something getting stuck, we want to know about that as well. And dysphagia is the fancy medical word that we might use for that difficulty swallowing. And then really any change in bowel habits, particularly as you get older, we want to talk about with you as well. Even if this might not feel very comfortable, it's important to share with your doctor. Next slide, please. So doctors might ask you, when did your symptoms start? Have you noticed any patterns? Is there anything that make your symptoms better or worse? And those are things you may want to think about so that you're prepared in advance to answer those questions as best you can. And it's also totally fine to say, I'm not really sure. I think for many of us in the pandemic, time kind of blurs together. And sometimes we'll ask, well, thinking back to a holiday, did you have those symptoms then? Next slide, please. Good doctoring requires good listening. If you feel like your doctor is not listening to you, let your doctor know. You may need a different doctor because listening is really important. Ask questions if you don't understand what your doctor is saying, and if you need to, set up a follow-up appointment. Next slide, please. We care about your most embarrassing problems, including trouble controlling bowel movements. Your quality of life is important. Many people avoid talking about that loss of bowel movement control, but there are things we can do to help. So do talk to your doctor. The last thing I'll say very quickly before wrapping up is that some of the other speakers have talked about family history, and there are online tools. You may not know your family history. Often there's one person in a family who really knows. Talk to that person before your doctor's appointment so you can get as much information as you can. And if you're adopted or you just don't know your family history or your people don't talk about that, that's okay too. And we know that happens. Next slide, please. This is an example of a worksheet for family history. Next slide, please. And that's it. Thank you very much.
Much, Dr. Garman. Our last speaker tonight is a colon cancer survivor. She had a colonoscopy, even though everybody was telling her that she didn't need it. So now she's here today to tell you her story. Thank you, Ms. Winnie.
Thank you so much. Thank you, guys. Good evening, everyone. I'm the one that's not accustomed to doing this. And this, as I said to Peggy, and I told my husband today, every time I think about this journey, and I've told my daughter as well, it's as if I've closed myself into a tube and closed both doors, and I'm in that emotional vacuum and revisiting this whole thing, but I'm getting better. So if I become emotional, I apologize in advance. Thank you so much for coming, everyone. And I'm very, despite the nerves that I'm going to have at first, but anyone who knows me knows that I like to talk. I am very excited about the possibility of sharing my experience in the hopes that it might improve in someone else's life. My name is Winnie Ray. I'm originally from the Bahamas. I'm sharing that more so than explaining the occasional accent that you'll hear, but also what I'm going to mention later on about a trend that I've seen with my classmates. It's more common than I ever would have thought in a small country. I came to Raleigh, North Carolina, approximately 45 years ago. I met my now husband. We will have been married 40 years this year. And we recently relocated back to the area, and we're very excited that we ran into Peggy, and bam, here we are. So this is the way change happens. We just need to accept it and move on. As I look back into my whole cancer journey, I think the first step that I can possibly connect to cancer at all is when I went for my 45th birthday checkup at OBGYN, and she did a stool test. And the stool test showed a small amount of blood. And we were able to, between she and I, because I was very convincing, I'm sure, we were able to explain it away with a hemorrhoid that I had gotten during childbirth. So we tested it then, and it was just a little. She wasn't concerned. And then we tested it one more time after that, and it wasn't present. So it went away. About 3 years later, when I was 48 years old, while I was working in Richmond, Virginia at that time, one of my coworkers came into the office and said that she just had the most embarrassing thing happen in a meeting. She started hemorrhaging from a hemorrhoid. And she contacted the doctor, and they explained to her that what she needed to do was to go to have a colonoscopy done. It connected with me immediately because I remembered the whole hemorrhoid, only child, and we need to check on it. So I offered to be her buddy, and we decided it would be really cool if the two of us could just go visit the doctor, have these colonoscopies done. And if things went well, we just have a cocktail afterwards and talk about and laugh about it later. So after a while, we did that, or so we thought it would be that easy. It was easy for her to do it because at the time she was probably about 53. Unfortunately, I was 48, had zero symptoms, and the doctor that would be doing the test for us, he indicated that he didn't think the insurance company would pay for it. Well, I just couldn't believe he thought that I wouldn't pay for it myself if I thought there was a problem. And I explained to him my concern that I had about having had a similar hemorrhoid, and I was afraid it might happen to me. It didn't matter. He really thought it would not be paid for. So I talked to my husband, and we decided that we'll just go ahead and do it, and I did. My coworker got her test results back pretty quickly, probably within the 7 to 10 days that she expected. I really didn't think anything of it, that I did not get my test results back immediately, because of course I was fine. I knew I was fine because I didn't have any symptoms and I had no reason to be there other than to be a friend. Well, it turns out, once the doctor did get back in touch with me, when he called that day, one of the first things he said to me, he said, "Are you alone?" And I said, "Yeah, I'm at work, but I am alone." he said, well, good. He said, I wanted to talk to you about your colonoscopy. I said, okay. He said, you have a malignant tumor and we need to go ahead and have it operated on. And I sat there and I thought, malignant, that's funny. I always thought benign was the bad word, but it's malignant the bad word, or is it the other way around? I convinced myself that he was just trying to remove something that was just in the way, kind of like a hemorrhoid. And he went on to explain that no, he wanted it done as soon as possible. And if at all possible, within a month, because he really wasn't sure of the exact status without going in and having someone go in and get further information. So needless to say, my entire world absolutely just crashed. I absolutely thought I was going to die sitting there. And I pondered so many different things and thought about all the things I could do differently to get out of this. Why did I come in the first place? And this went back and forth. Needless to say, we went ahead and we decided that we would get a surgeon as quickly as possible, and he then became the best person I could have hired for the job. He became my best friend, supporter, and talked me through all the things I needed to know. I had to be sure to share everything that was possible that was related to it. And we went ahead and we established a date for the surgery for as July 21st. When we got within 2 days of July 21st, which happened to have been my mom's birthday, he called and he said, I really hate to do this, but I'm going to have to reschedule your surgery to July 27th. He said, because we've had an emergency come in. And I said, okay. And he said, why are you smiling? I said, well, because it's my dad's birthday, my late dad. And I think it's God's way of letting me know that dad's involved and I've got an angel working with me. So I became more hopeful and we went ahead with the surgery. What I learned most about the surgeon in that role, it was so important. He became my advocate. He became that person I could call in the middle of the day while I was trying to work. There was an interim period of 1 month between finding out and having to have the surgery. And I could call and ask him anything. He was always willing to work with me on that. He explained that his role was really to go in, and in my case, because I had colon cancer, and they weren't quite sure of exactly how many of them were cancerous. But at the end of the day, he would go in, categorize it, make sure he understood whether or not it was able to go beyond the colon and come out with recommendations for long-term treatment. So going into the hospital, there were a lot of questions. There was a lot of concern. I was scared. And as a patient with a family, I think the biggest thing was I was so busy trying to say everything in a way that didn't scare them. I had friends around me as well, close friends that were very, very helpful. But I was able to get through it all because at the end of the day, we went ahead on July 27th. We did the surgery. It was a success. He was able to remove, and I'm trying to say some of the correct words. I didn't go back and dig up my files and get the proper phrase to impress our doctors here, but there was a bisection. Approximately 18 inches of my colon was removed successfully because the cancer was self-contained within that 18-inch section of it. It was down in the sigmoid area of the colon, which is down in the lower fourth, I think was mentioned earlier, in the lower fourth of the colon, just prior to, coming down to the final corner and going down into when feces leaving the body. So that's one thing you do learn, by the way. I don't get embarrassed talking about it. And I can't believe I do that, but I don't. So we were able to remove that part of it. I stayed in the hospital. I had a few small complications, nothing major. When I say small, I mean I had unexpected fevers. I had some complications with the tubes that were inserted and things weren't flowing in the right direction. I had one friend, and I hope she's on here tonight. I'm not sure if she got to register, who is a registered nurse from Richmond, Virginia, who moved into the room with me. And she got to hear me talking out of my mind on drugs during the middle of the night. And I heard about it and I continue to think about her all the time. She'll always be one of my best friends because she stayed and stuck through it all in the hospital. Of course, my family was there with me, but this particular person had no reason to subject herself to that, but she did. Thank you. So that happened, and then we're out of the hospital. One thing I'll mention very quickly, when I left the hospital as a new woman with a slightly shorter colon, I realized very quickly that my life was different. The grass at my yard was greener, the crepe myrtle, the flowers were prettier. Everything was just amazing. And I know that in my rush, as I was going through this just now, to get this done, because I realized 10 minutes and then I'm going to have my person pop up and say you're out of time. But one of the things I did in that interim month before I went to the hospital was I started negotiating with God. And I negotiated. I said, God, Christina has just started, she's just finished her freshman year. If you could just let me live long enough, change the slide, please. If you could just let me live long enough so that I can see Christina graduate from Duke, I will be a happy mom. About 2 days later, I realized I didn't ask for enough. So I went back and I said, God, if she can graduate, maybe she'll have a boyfriend. If you could just let me see her get married, maybe it'll take a little longer, but I really want to see her get married. And maybe one grandchild. That would be a blessing. And so those were the things I was focused on. I even wrote an obituary during the whole thing, because I will tell you, I never really got to the point in the short term where I felt I'm done, I'm happy, I'm walking out of here, because it is a journey. It is a journey that requires that you monitor yourself and you make sure that all of the concerns and things that you're going through, that you contact your doctor and talk about them, or you make notes and talk to someone else to make sure you get to the right person. But what I did not ever do, I can't believe I didn't, but I did not Google it at all, because my surgeon made me promise not to do it. And that was very easy because I was going through too much. And I didn't do it, and it was great advice. Once I was out of the surgery, and I'm fairly comfortable now, in the first 6 months, I was worried, and I went back to my surgeon's office, and at two occasions, and I convinced him that I needed sigmoidoscopies, which was just mentioned a minute ago, because I was having a lot of discomfort and the inability to have bowel movements quite easily. So I was afraid of a blockage. I was afraid that when he explained how they joined the sections together, it didn't seem like that would work to me, because now I'm a doctor. And they did it. They did whatever I needed to feel comfortable that they were doing the right things for me. It's so important to communicate to your doctors. After that, so that was 2006. For the next 10 years, my husband and I, on a regular basis, annually, we went off and we had colonoscopies early in the morning. It became our journey, and very matter of fact. And on quite a few occasions, we had precancerous polyps. There were a couple occasions, I think, we just had polyps that were not the most attractive, but they weren't precancerous yet. But in 2016, something magical happened. We didn't have any polyps. So my gastroenterologist now has decided this is a great time to take her off the annual basis and to go ahead and to give her a 5-year break. Well, at year 4, I was panic stricken. I was having discomfort, and the doctor went ahead and he went ahead and did a colonoscopy out of sequence. And what we discovered was that I did in fact have a benign cyst on my liver. So going forward, in addition to monitoring my colon, as I continue to do on a regular basis, I am also now monitoring my liver on an annual basis, but it's a small price to pay for my good health, my happiness, and the ability to be with my loved ones. Trying to see, just give me a minute. The fact is, I'm a 15-year survivor now. I have traveled, I have lived, I have loved, and I'm very, very happy. I will share with you a statistic because I am of Caribbean descent. And for something I find fascinating is that there are five individuals that I know of personally, 2 of which were diagnosed later on in the 4th stage, and they passed almost immediately in less than a year. 3 of them were diagnosed earlier on, like I am, and they are doing just fine. But the fascinating thing, because so many people have said to me, I thought it only happened to men. Not so. 4 of those people were women. So we need to be sure to become our biggest advocates and to know when something is feeling different. You're not supposed to feel aches and pains in your tummy on the regular. It's just not a part of aging. So you need to do that. And the life lesson is that we know our bodies better than any doctor, family, or friend. Follow your instinct. Early detection saves lives. And I thank God for my daughter, her husband, the 3 granddaughters, and my very, very loving and supportive husband. And thank you for the opportunity to share my story.
Much just waiting for sharing your story. We really appreciate it. Now we're going to do some questions and answers. Amanda, you can take it away.
All right, thank you so much. That was a very touching testimony and story, Ms. Winnie. Thank you so much for sharing with us. It is the
Thank you.
testimonies of those who have gone through sometimes inspire other ones to go and get tested. So thank you so much. Thank you to our doctors, Dr. Wilder, Dr. Epstein, and Dr. Garman, and to Dr. Moore, and to Kirsten for joining the team and being part of this and making this into a reality. Yes, I do go on Facebook and I do rant about health issues that just kind of sometimes take me away. And thank you, Pegy, for coming on board and helping me get my rant out. So we do have questions. Here we had some questions that came in prior to the event. And I just want to let everyone know that our doctors online cannot give medical advice because you're not a patient of theirs. So, and then there are questions that are on here that are not really related to what we're talking about today. So we cannot address those. I would say for those questions, if I skip over you, it's not because I did not see your question. It's just we're trying to stay on topic here. One of the questions that one of our registrants
asked is irritable bowel syndrome. I'm sorry, that was is diverticulitis. Yeah, how can you help? What medications can she take for diverticulitis? I'm assuming that's what she's asking. Any of
I
our
can
doctors?
answer that maybe in a very general way. Diverticulitis is considered an infection and is usually treated with antibiotics, although sometimes is treated conservatively. And if it continues to be a problem, sometimes it's treated surgically. And it's where there are these outpouchings of the colon through the muscle wall. So when we do a colonoscopy, we see these sort of little caves. There used to be a lot of dietary restrictions for diverticulosis, where you just have those outpouchings, and those are no longer followed. But I would say if you have a specific individual question about diverticulitis, I'd really encourage you to talk to your doctor about that problem.
Okay, thank you, Dr. Garman. There is a question in here in our recent on our online audience. It says, can gastroparesis be cured? Or I guess you can explain what gastroparesis is.
Right, so gastroparesis is slow gastric emptying, and there are lots of different things that cause it. And it can be a really vexing problem. So sometimes people will have it after an infection and it will resolve as the stomach heals. Sometimes it will be related to diabetes, and better control of blood sugar can improve it. But it's a very individualized issue and can be really problematic. And I think it's one of the things that's probably best handled one-on-one with your doctor, as you try to think about what the cause might be and what might help. In general, we recommend small, more frequent meals, knowing that your stomach's going to empty more slowly, and avoiding fatty foods that may slow stomach emptying. And I don't know if Julius Wilder wants to add to that at all, but that's a little bit of general information about slow gastric emptying. I will also say, if you're having a lot of bloating or gastric upset, we really do recommend you talk to a doctor, because we also want to make sure there's not an obstruction there. And so getting an endoscopy is often part of that evaluation.
Okay, thank you, Dr. Garman. Next question here is, does that mean, I'm not sure what the writer is referring to, but does that mean that abnormal LFTs or liver function tests, for those who may not know what an LFT is, or a lipid panel test, are inversely related to colon cancer risk? I think that's a Dr. Wilder question.
Sure, yeah, I can, yeah. So no, there would be no correlation between those tests necessarily and your colon cancer risk. No.
Okay. Mm-hmm. So this person said she had a client that found out that she had an infection from an abnormal liver testing doing a liver exam for insurance. I'm not sure if that is a question or if that is a statement. So going back, what can we proactively do to improve our gut health? And I think that was somewhat addressed, but if anyone wants to take that. What can we proactively do?
Yeah, there are a number of things, we suggest. I mean, probiotics are one of those things that people speak about, all the time, that you can take and you can get that over the counter. But quite frankly, I tell all of my patients, number one, be aware of foods that upset your stomach. If there are things that you eat that make you uncomfortable, don't eat those things, or limit, your intake of those things. A diet that's rich in fiber, a healthy diet that also includes things like fresh fruits and vegetables, we know is also very good for your gut health. And we also know that those types of diets are less likely to result in the kind of environment where you're likely to have polyps or develop colon cancer as well. Eating meat is okay, but certainly all these things should be done in moderation and balance with a healthy diet. But certainly, a healthy diet that's rich in fruits and vegetables and fiber, we know it's going to be something that's going to be good for your diet. Now, I'm going to also say, however, that if you notice uncomfortable changes, and I tell my patients all the time, they're like, well, I'm eating all this fiber and I feel like a little bloated and I'm having gas, well, then don't do it. So remember, and that's why the first thing I said, is that we know that these things are good for you. These things can make your gut sort of improve your gut health. But if you find these things to be, upsetting your stomach, no matter what it is, then I always suggest to my patients that they stop eating it.
Okay. So this person wants to know, will the insurance company pay for a colonoscopy for a patient who is younger than 50? And I can answer that one because you can check with your insurance company because what insurance an insurance company covered varies with each insurance company. Also, the American Cancer Society has decreased the age from 50 to now 45. So most insurance companies are now picking that up at age 45. And I think there was something else there about if you have a family history, you can get a colonoscopy sooner. Is that correct, Dr. Garman?
Yeah, absolutely. If you have a family history or if you're having active symptoms, there are a lot of things that can justify a colonoscopy sooner. And I think being your advocate, as we heard Mrs. Ray so powerfully share, is really important, and making sure that your doctor really hears those concerns, critically important.
Okay, thank you, Dr. Garman. And that seems to be all of our questions.
There's a quick last question in the chat about making sure information isn't overlooked on lab results, especially as a minority. And I would say so often now our results are released electronically and there may be no explanation. And I think it's very reasonable to ask your doctor if you have any questions about results that come back, to make sure that you understand both what the tests are and how to interpret the results, because sometimes it can be really confusing. And so I would just say, if you don't understand, please feel free to reach out. And if anyone else wants to address that, feel free.
I have a quick question. We just relocated to this area and I'm having a difficult time finding a gastroenterologist that's fairly close to it, not necessarily where we live, but that I feel comfortable with. I don't even know where to begin sometimes. So I probably offline, I would appreciate any feedback I can have. I would appreciate it.
Okay.
Absolutely.
Okay, so here's another question. What can people who are younger do now to promote healthy gut and prevent issues as we age? I'm assuming this person is under 30.
It's a really, really important issue. We've seen a lot in the news about cancers in young people, and the screening guidelines sometimes don't extend, but I think being aware that if someone is having symptoms, those red flags in particular, to seek out a doctor and talk about it, even if you're young, and not just chalk it up to some other issue, but really being vigilant about getting it checked out and supporting that in our friends and other people we know, and then doing the best we can to stay healthy. That may seem like a simple answer, but it's something we're really wrestling with, is how to better understand and prevent cancers in young people as well. Thanks for raising that important point.
Yeah, I have to emphasize exactly what Dr. Garman said. I mean, you're never too young to really engage in a healthy lifestyle. And the dividends, will sort of, you reap dividends far beyond just your gut health, your overall health, certainly. But yeah, I mean, absolutely doing those healthy things right now will have a big difference, including, as she put in the chat, things like exercise, along with the dietary changes as well. Avoiding alcohol, avoiding smoking, those kinds of things, the kind of habits, things that happen in college, right? But those are habits we've got to get rid of and get you in trouble.
Thank you so much. And you can continue to put your questions in the chat or respond to what Peggy's going to say next, and we'll see if we can get those things answered for you. Thank you.
Okay, I got my video going. Listen, we just want to appreciate everybody, love on everybody. I think Amanda's already said thank you to all the doctors that were involved tonight, and Winnie Bowe and Dr. Angelo Moore. You've been such a blessing to us. Thank you, thank you, thank you, and to the interns. Dr. Wilder, we'll be seeing you again, Dr. Epstein and Dr. Garman. Thank you. Next slide, please. The Gut Patrol, you're going to be seeing this logo all over the place, so get used to it. You'll see t-shirts and hats and some other stuff. But just remember to visit your doctor if you have symptoms, schedule your colonoscopy, eat more fruits and vegetables, and for patient navigation, I don't know if we talked about that tonight, but if you need help or directions on what to do, who to go to, any questions, call the number that's on the screen, 919-684-0409. And Miss Aretha Cooper, she's got an email address there at duke.edu, and that's the same email address that was on the registration form. So if you got any questions, reach out to them. They're very resourceful. Next. And so what's next? We got a health fair coming up. I know you all learned some stuff tonight. You have other questions. So if you have more questions, come join us on March 19th over at the Life Enrichment Center. We'll have Dr. Ruth Phillips with the Community Health Coalition. She's a very good resource in the Durham area, but she handles most of North Carolina too, with some of the initiatives that she has. She's going to be, she and her team, that is, they're going to be doing blood pressure checks, colon screening kits, and passing those out if you fill out the questionnaire. And there's an incentive to that you will be able to get a $25 gift card if you fill it out and take the colon screening test. Got to fill it out and send it in, okay? There'll be vendors, food demonstrations, food giveaways, music, exercise, and blood pressure checks, like I just said. Dr. Eplum will be with us again. Dr. Angelo Moore will be there. Now, you didn't get a chance to see him tonight or hear him talk, but he has a plethora of information that you need to know about, especially if you don't have insurance or you just need to know about different services that are in the area. He's the guy, he's the stat man. And Dr. Gail Jones will be with us. She's a life and health coach. And she'll be talking to you about more about your mind and eating. That's March 19th, put it down. Let's go to the next slide. Also at the health fair, here's some of the other people that will be involved. We're going to get up and move. We're not just going to sit. And we'll have Darrell Young out of Charlotte. He's coming down. He's one of our Silver Sneakers instructors. So for the old folks, you might want to follow him. For the middle ones, you might want to go with Cynthia Jones. She's a neo-soul recording artist. She's going to be teaching us a line dance. So between the talking, we're going to be dancing too. And then Gerald Hinton, he wants to be a part of it. He was with us when we first got the presentation. And he says, I want to be a part. So isn't it good to know people that just want to be a part? They see you have a good thing going. And Terry Spicer, she'll be there too. Terry has this thing called Fit Pearl, and she'll be giving her testimonial. Now we're also partnering with the Black Farmers Hub here in Raleigh. And so we have, he calls himself Bear. His name is Kelvin Gervais with the Black Farmers Hub. He's going to talk to you about food is a drug. And further down in the spring or summertime, we're going to be talking about gardening too, how you can grow your own garden. And Kelvin is going to help us with that if you want to be an urban gardener. And also at the Black Farmers Hub, we're going to have Demetrius Hunter. He's going to be doing a food demonstration along with Melissa Moore. She has a vegan cookbook. And so you'll get a chance to sample some food. And we'll also have a testimonial by Ardretta Hall. She's on the line, I think, tonight. I think I saw her picture in there. So how do you get a chance to register? Go to the next slide. Let's see, do we have it on the next slide? Here you go. Take a picture of this. Yeah, they got me all into this technology stuff. If you want to register, or you can just go to the link on the very bottom. But where we want you to go is on Facebook to the Gut Patrol Facebook page. We've got a lot of stuff that's going on that page, a lot of information. We're going to be doing some fun things. So just ease on over to the Gut Patrol and join us. Next slide. Let's see, what do I have? Oh, the next slide is just a thank you, thank you, thank you, thank you. And once again, we're asking you to join the Gut Patrol on Facebook. Spread the word. We hope you learned something here tonight, and we do appreciate you coming. Is that my final slide? Do we have any other comments from Amanda or anyone else that was speaking tonight? If not, I just want to say a final thank you for taking your time. I know you had a busy day, so we say thank you. Any more comments?
No, I just want to say thank you, Peggy. Thank you for believing, thank you for listening. Thank you for hearing. And
Oh.
thank you to, like I said, the other doctor, and the other doctors, and,
Okay.
everyone.